Welcome to your daily guide to your new hip replacement. My name is Brett Levine. I'm an associate professor at Rush University Medical Center, and I'm going to take you through the process of going through your new hip, preparing preoperatively, moving through the intraoperative aspect of it, and then the course in the hospital. Listed here are my staff. You can see my administrative assistants, Stephanie Palomares, Kathleen Flores, as well as my physician extenders, Emily Stoffer and Crystal Lasakis. They'll be helping me throughout the course of your hip replacement, and they are there to help get you through and can answer many of the questions that you need regarding the surgery. And I am always available as well at this phone number. They'll get me on the phone, or you can reach us through this secure email address, morajointdoc@rushortho.com. Our office locations include Rush University Medical Center. We're in the orthopedic building. We also have an office at Prairie Medical Center where we see patients up on the second floor, Suite F. These addresses are the offices in which you can be seen pre- and post-operatively. You may follow up in an office that is easiest for you to get to and does not necessarily have to relate to the hospital that you have surgery at. The hospital locations that we work at include Rush University Medical Center, 1653 West Congress Parkway. The check-in is on the 4th floor, so when you pull into the parking garage, if you come up the 4th floor, you'll see a connection to the hospital. Elmhurst Memorial Hospital is the second hospital that I work at, and that is at 155 East Brush Hill Road. You check in on the 2nd floor and enter the main entrance. Surgery can occur at either one of these locations. It's depending upon the availability of the surgery date and your preference for the location of hospitals. As a means of disclosure, I've listed here the different things that I do consult for, different companies I do consult for: Zimmer, Link, OrthoView, and McGraw-Hill. We do receive research funding from Zimmer, Artelon, and Biomet, and I do get some book royalties from writing books for Human Kinetics and Slack Incorporated. The following is an outline of what we're going to cover today through this slideshow. We're going to cover the preoperative aspect of the surgery, followed by the hospital stay, discharge, and then what's going to happen when you go home or you go to rehab, basically that postoperative course. So these are the things we're going to cover throughout the slideshow. We'll try to cover it for you in a relatively expeditious manner so that it doesn't take too long to listen to this video. In the preoperative phase, essentially at this point you've decided you want to have a hip replacement. So what's the next steps? You're going to need medical clearance, which usually involves your primary care physician, possibly seeing some subspecialists depending upon what medical comorbidities and other medical problems you may have. And then you're going to need to prepare for the surgery yourself. So that includes some mental preparation, possibly a little bit of prehab, and then there's the night before the surgery as well. We'll cover each one of these points in a little more detail here. So typically you're going to need to see your primary care physician. This is nothing special other than a basic history and physical that's performed, including standard blood work, EKG, chest x-ray if deemed medically necessary, and any other tests that your primary care doctor would want. Again, we leave this up to your primary care doctor for the medical clearance. It is important that they do this clearance because surgery does have risk, and we need you to be medically optimized for the surgery. Each hospital has a certain amount of time that blood work, EKG, and chest x-ray may be good, as well as subspecialty notes, so you may have to repeat some of these if it's outside of that window. Typically, it's anywhere between 30 and 60 days that a lot of your tests may be good and count for your preoperative clearance. If you don't have a primary care doctor, we'll attempt to find one for you at the hospital that you choose your surgery at, so someone from that group or that particular physician could see you in the hospital after the surgery. If you do have multiple medical problems, you may be asked to see other physicians, including if you have heart problems, a cardiologist. A stress test or an angiogram could be ordered. If you do have diabetes or any other endocrine issues that are not under control, you may be sent to see an endocrinologist. Particularly for those who are diabetics, we like to see a hemoglobin A1C not being any greater than 7.5. If it is 7.5 or just above, then we're going to want to see a week's worth of blood glucose measurements and make sure that 90% of them are below 180. Above 180 for your blood sugar count can lead to problems with your white blood cells and an increased risk for infection. Therefore, again, we like to optimize this preoperatively. If you're suffering from Morbid obesity, we may need to have you see a nutritionist. A BMI greater than 45 increase the risk of surgery to the point that it may actually outweigh the benefits of having the surgery. Major complications can happen into 30 to 35% of patients when their BMI is over 45. And then if you do have any dental problems, you're going to want to make sure you take care of those preoperatively. So see your dentist, make sure you're cleared and there's no evidence of infection or problems that are pending in your mouth. Are you ready for surgery? This is a question that patients are always toying with. The question is, have you exhausted all forms of non-operative management? If you have, then there is nothing left to do. Then surgery definitely is your last option. And that's what we like to reserve it for. It is your last option because this is called a replacement. We're going to replace your joint. I typically try to get people to try as much as they can all forms of the non-operative management, including injections, anti-inflammatories, maybe even some physical therapy, depending upon your arthritis. So we try to make sure that at least you do understand that you've exhausted everything and now you're mentally prepared because there are no other options. Do you understand the risks and benefits of the surgery? So the benefits we've kind of mentioned a little bit, and you should understand a return of function, decreased pain, and so on. The risks of surgery, there'll be a separate PowerPoint you can find on the website, but any type of surgery certainly has the risk of anesthesia. With hip replacement, we run the risk for having an infection, nerve injury, need for transfusion, early dislocation of the hip, limb length discrepancy, and occasionally, and on a very rare occasion, there can be loss of limb or loss of life. Again, this is almost never happens, and most of these complications are incredibly rare, but they are risks of surgery, and you have to weigh that against the benefits mentioned. The other question that people tend to ask are, or I ask of them, do you have the appropriate expectations of surgery and recovery? This is a hip replacement, and you're going to have to recover. We like people to take it easy for the first 4 to 6 weeks. That doesn't mean that you don't have to do anything, but we do like you to take it easy for the first 6 weeks as the implant is starting to stick to your body, and your bone will actually grow into the holes of the metal of the implant. If that happens, then your implant will be with you for the rest of your life, and that is one of the most important parts of surgery. So what we want you to do is take it easy in those first 4 to 6 weeks with sporting activities and such, and if you do, you'll have an excellent long-term result. We also have to have you understand that this is not going to make you feel like you're 20 years old again. If it did, I think many of us would be having the replacement just to feel 20 years old again. Essentially, this is going to help you with walking, non-impact activities, bicycling, swimming, activities of daily living. Those things are going to get easier after the surgery. These replacements are not great for running, jumping, and high-level sporting activities. That's not really the best reason to have a replacement. If your expectations are in line with what you're going to get, you'll be very, very happy in the end. We do suggest that you've read all the paperwork in your preoperative folder, and then you've thought about your discharge plans preoperatively. So you should think about home versus rehab. What is your home setup? Is there going to be someone there for you? Ideally, we'd like for all people to go home if possible, as that lowers the risk for having you still being institutionalized, but it's not always possible. So these are all the questions that should be going through your mind, and you should try to have answers for these preoperatively. So again, are you ready for the surgery? There's some prehab that you can do, preoperative exercises. For the hip, you're going to focus on your abductors. So that's when you're standing, you're going to take your leg out to the side, either standing or laying down, and you're going to work on the muscles on the side of your hip. Hip flexion is not bad either. Hip stretching, where if you stand with your hands up against the door and you bring your hip back, so you extend your hip. If you work on that, that is great. If you pull your knee towards your chest, that is great. These are all things that can definitely help you with your postoperative recovery. Cycling or elliptical for aerobic training is great. Again, do what you can for prehab. Prehab is not meant to be torture. It's meant to just kind of help you get ready for the surgery a little bit more. You could start this with the physical therapy before surgery and get 1 to 2 sessions before. We like to give you that prescription at our preoperative visit so you can get that started and learn what exercises you're going to need postoperatively, and you can hear that before the surgery. Try to maintain a good diet and keep your weight appropriate, keep your blood sugars appropriate. Lots of protein is good for healing after the surgery. Again, are you ready for surgery? With our protocol, we'd like you to start the stool softener we've given you in the office at your preoperative visit 48 hours prior to surgery. That's to help combat the constipation that's going to come after the surgery. So we try to get that going a little bit before the operation. So 48 hours before, we suggest you start on that stool softener. We suggest you use the HibaCleanse or the chlorhexidine soap, wipe, whatever you decide to purchase, to shower with your whole body except for your face and hair for 3 days prior to the surgery. 3 days is the minimum, 5 to 7 days is the maximum. But if you do shower, this will decrease the risk of infection by 30-fold. You should fill the prescriptions that we gave you and set up your physical therapy if you're planning on going home. If you fill those prescriptions, they'll be waiting for you at home for your medicines, and the therapy you can set up for a few days after the surgery. We do have some patients try OxyContin before the surgery, a few days before, to make sure they can tolerate it, as well as taking one on the morning of surgery. It's not common that we do this for patients that are having hip replacements unless you have a history of taking narcotics in the past and you may have a little bit of a tolerance to narcotics. But this is something that we can use if necessary, but don't often use for hip replacement. The night before the surgery, you should have nothing to eat or drink after midnight. You should check with your medical doctor if there's any specific medications that they like you to hold or continue. Blood pressure medicines, diabetic medicines, they should hopefully give you a pretty good guidance on that. If they don't, then you certainly can give us a call, but they would be the better person to discuss that with. We do suggest you stop all your anti-inflammatory agents at least 5 days prior to surgery, and aspirin should be 10 days before surgery. Otherwise, you can have a little excess of bleeding during the course of the operation. Again, that's also any blood thinners should be stopped, directed by your primary care doctor. Whatever they say, and whatever bridging, meaning if they want you to take something else after stopping your blood thinner leading up to surgery, then you should consult with them, and they should make sure that they give that to you. So again, just make sure you're not taking your blood thinners or you're handling it as per your primary care doctor leading up to surgery. If you're feeling ill at all, call my team to alert us. You have the number there, the email address. It's not good to have surgery on a day where you're not feeling good. We certainly can move your surgery back a week or so and get it to a point that you are feeling good. You don't want to be trying to recover from replacement surgery when you're not feeling well. The last thing before surgery is that the hospital will call you the night before to tell you when to arrive for surgery. They're the only people to tell you when to arrive for surgery, so they're the ones responsible with that duty. We do try to respect if you have a preference, if you call or email ahead of time. We try to respect a preference that you may have, but the hospital will tell you when exactly to be there. On the day of surgery, what should you expect? Well, anesthesia is going to come in and they're going to talk to you. Typically, they're going to tell you that they like to do a spinal or an epidural type of anesthesia with twilight sedation. I think that's probably the best. Spinal or epidural is typically what we call a regional anesthesia, and that is the best for replacement surgery. It does decrease the risk for blood transfusion and blood clots, so it is the best way if possible. If you've had spine surgery or other surgeries in the past that prohibit this, or it is your preference that you do not want to have spinal or epidural anesthesia, then it will certainly do a general anesthetic for you. The surgery itself usually takes somewhere between 60 to 90 minutes. You're going to be on your side for the surgery. We do put padding on the opposite side so that doesn't get too sore, but occasionally people will have a little bit of pain on their shoulder of the opposite side of the surgery, and even that hip because you're laying on that side. We do like to place a Foley catheter for the first 24 hours into your bladder so you don't have to worry about going to the bathroom. Additionally, when we use regional anesthesia, it's oftentimes very difficult to go to the bathroom in the first 24 hours, so that's why the catheter is in. If you did elect for general anesthetic, we certainly can remove that catheter in the operating room or in the recovery room if you want, but with the regional anesthesia, we try to keep it overnight. Blood transfusions are rarely performed intraoperatively, and we do a good job in screening preoperatively and getting people prepared, and we use a couple of new medications that have been out for a long time at this point, but new to joint replacement that have really decreased the transfusion rate. So unless you're anemic, it's very rare to require an intraoperative blood transfusion. Once you hit the recovery room, you can expect to be in the recovery room for about 90 to 120 minutes, and then they'll get you up to your room. Nausea and pain is typically controlled for you at that time. They're going to work on making sure that's covered. Typically with regional anesthesia, you're not going to have a whole lot of pain. May have a little bit of nausea, but with general anesthetic, they're going to work on catching up with your pain, as well as dealing with any nausea that general anesthesia may cause, and then they'll go ahead and get you transferred up to the floor to your room. An x-ray will be taken of your hip at that time in the recovery room, just to make sure everything is good, as well as to be our comparison for all future x-rays. You'll be a little bit groggy. You should have minimal pain if you had the regional anesthesia, but overall you should be slowly coming to. While you're in the recovery room, I'm going to go discuss the surgery with your family so that they're ready for you and they'll be prepared to meet you up in your room. And again, probably somewhere between 90 to 120 as far as that timing goes after the surgery. Once you get in your room, they're going to make you comfortable, get you settled. You'll be given clear liquid diet and then slowly progress to a regular type of diet or a solid diet. It's not a good idea to jump right into eating a big diet once you get to your room. Start slow with the fluids so you don't get nauseous from the anesthesia and the medicines. If you arrive early to your room that day, so the surgery is in the morning and you get there before 2 or 3 in the afternoon, physical therapy typically will see you. You'll stand, hopefully walk that day and maybe even go out into the hallway. If you do not work with PT, then you should ask the nurses to sit you at the side of the bed and dangle your feet. It's a good idea to do that on the day of surgery. Just shake some of the cobwebs as you sit up for the first time and gives you a chance just to get your equilibrium going so that the next day physical therapy can really get going. The first time you stand up again, you will be dizzy. You're going to get a little lightheaded. It's normal. Take your time standing up that first time. And again, that's why we like to get that out of the way on the night of surgery. So the next day you don't get that feeling and you get up and get going pretty quickly. The first evening, you should really try to get some rest. A sleeping pill is ordered if you need it. Take your pain medicines if you start to feel any pain as the anesthetic starts to wear off. Don't let the pain get ahead of you. If you get ahead of the pain, you'll be much happier. And if you get a good night's sleep the first night, you'll be really ready to tackle that physical therapy the next morning. You can put an ice pack on the side of your hip. You can elevate your leg. You don't really need an ice machine because those are very difficult to attach to the hip. So just an ice pack on the side of your hip, elevate your leg, and that should help with swelling. Your opposite hip may again be a little bit sore from being on that side. You can lay on either side depending upon whatever you tolerate better. They'll just put a pillow between your legs. And then get prepared because tomorrow's going to be a big day with physical therapy. So it begins on day 1. It's the toughest day. Anesthesia's worn off. You're trying to catch up a little bit with your pain medicine. Hopefully you are out in front of it, but you can expect some pain. The day before, the anesthesia was likely still working, and it really didn't give you an accurate assessment of what walking was going to be like. At this point, you'll have Norco, possibly OxyContin, depending upon your pain level, and morphine and Celebrex for your pain. All of these work differently and will help attack the pain from different avenues. Some are short-acting, some are long-acting. In any event, overall, they should really help take down your pain. If they don't, we certainly have other regimens we can switch to, so you just let us know if it's not working. You take your pain meds as you start to feel the pain, and don't let it get ahead of you. Again, you're going to ice elevate, and when you're walking, really focus on standing tall, walking heel-toe, and do not focus on your limb lengths. Everybody feels like their operative leg is long to start. And the leg is heavy, the muscles are a little stunned, and it just doesn't feel the same. So give it some time. Don't focus on your limb lengths. Just try to walk heel-toe and stand up tall. Did I mention stay ahead of the pain? I really think you need to do that day 1, day 2. Make sure you're consistent in that pain medicine every 4 hours or so for the first 10 to 14 days. You'll just be a happier person. As you find you don't need it, you can stay away from it, but don't be a hero. Take the medicine as you need it. The surgery and rehab tends to hurt. You're not going to do any damage to your hip, but we do need you to push through with walking early because it does decrease the risk for blood clots and it does improve your outcome. So make sure you take your pain medicine so you can get going. On day 1, you're going to walk for sure. They're going to teach you some exercises. And if you're doing great, they may even do the stairs with you. The case manager will review your progress. Discharge planning will begin. And if you clear physical therapy, which means walking around a nurse's station and going up and down some stairs, we'll let you go home. There's no push to be the first person to get out of the hospital, but as soon as you feel like you're ready, there's no place like home, so we'll let you go. If you do need a rehab stay because home is not a safe environment or you don't have people there for you, then we may need to make those arrangements, but this will start on day 1 if it's something you might need. Your dressing will be changed that morning, and if things are looking good, we'll be able to let you start showering within the next day or 2. Day 2 is often the turning point. Now you've slept a little bit better on the night of day 1, and you wake up and you're going to feel a lot better. Again, try to stay ahead of the pain. When you wake up, we try to get back to a normal routine. So you can get up, have your breakfast, use the restroom, and maybe even shower if you want in the morning, just to kind of get back to a little bit more of a normal feeling and not so much the feeling of being a patient. Physical therapy is going to continue to work with you. They're going to focus on stairs. They'll work with you using either walker, cane, or crutches, depending upon whatever you need. Again, everyone recovers at their own pace, so don't worry about what everyone else is doing around you. Just focus on how you're recovering. Walk correctly, so stand tall, heel toe when you walk, and just do your exercises. Remember, your appetite's not going to be great at this point. Try to eat some healthy options if you can, because it's still important if you're a diabetic to make sure your blood sugars are good. And even if you're not a diabetic, we prefer you eat a high protein diet and low sugar diet if possible. So just keep those things in mind and keep your head up. It's going to keep getting better. Again, on day 2, one thing that we always worry about is constipation. So the stool softeners are given. You can get a suppository if necessary. But use whatever works normally for you. If prune juice is what it is, or coffee, or a special meal, whatever it is, use what you normally use that helps you be able to go to the bathroom. Otherwise, the things that typically are good for everybody are be ambulatory and active, and drink lots of fluids, and that should help. Continue your pain meds as you need them, and if you clear physical therapy, then you'll be free to go. If you are going to rehab, typically they require a 3-night stay, so you're going to stay one more night prior to your transfer to rehab. On day 3, things are really going to start to fall into place. You're going to be feeling a lot better. Discharge is going to be ready to occur or may have already happened. The pain will be a little bit better, but you're definitely going to have some pain with PT. Now, the big thing is that the swelling is actually going to get a little bit worse right now. Your leg is going to swell, the thigh is going to swell first, and then what will happen is at the end of the day, you notice your foot and ankle is swollen. This will happen over the next couple of weeks. At about a week and a half to 2 weeks, it'll reach its peak, and by 2 to 3 weeks, it'll really drop down and be almost normal by the end of 3 to 4 weeks. So don't panic. The leg is definitely going to swell. It's something that we do expect. You should wear your compressive stockings during the day to minimize the swelling, and then elevate your leg at night. If you're worried about a blood clot, certainly call us. If you're home, in the hospital, we'll take a look. But a blood clot is typically point tenderness, so a small area that hurts where you can put your finger on the back of your calf or the back of your thigh in a single spot that seems to hurt, and that's associated with a lot of swelling. They're pretty rare. We don't want to miss them, but we try not to overdiagnose it either. So remember, swelling is going to happen. Don't be surprised. It's only if you find the signs of really point tenderness in a single spot that we're worried more about blood clots. Again, you can shower, and you should be getting ready to head home or to rehab later that day. Bon voyage for everybody. At this point, on day 3, it's pretty rare that people need to stay unless more arrangements need to be made or another day is needed for the person to go home. Otherwise, typically everybody's on their way home, and the discharge paperwork is finalized. Continue to work hard when you're home. Your leg's going to feel heavy and sluggish. People typically say it feels like it's not theirs or it feels like a piece of wood, and they're just kind of dragging it along for the first few days. Very, very normal. This is going to disappear by a week to 2 weeks. The leg's going to wake up, swelling is going to start to disappear, and it's just going to feel more like your normal leg and going to get better. The operative leg is always going to feel longer. It may be a little bit longer, but it's always going to feel longer than it actually is in the first 6 weeks. Don't panic. Your pelvis is going to settle a little bit. The hip's going to stretch out. And over 6 weeks, it's going to feel like your leg is slowly shrinking. And by the end of 6 weeks or so, it's going to feel like what it is, which is usually very minimal if there is a difference. Don't get discouraged. It's going to get better, I promise. Keep your chin up and keep working. Do your physical therapy, and typically we'll see you in the office in 10 to 14 days or so, roughly. Upon discharge, don't be anxious. You're ready to go home to rehab at this point. You'll be ready. Therapy is going to clear you. You're going to be ready to go, and don't panic. If you have questions or concerns, call us anytime or email anytime at MORJointDoc@RushOrtho. It doesn't matter the hour of the night. Email will go through. If you call the office, you're going to have to go through a series of options, and just make sure you hit the option that it goes right through to the person on call, which usually would be myself or one of my physician assistants or nurse practitioner. So don't hesitate to contact us if there's questions. But remember, swelling is normal. It's going to peak about 7 to 10 days after and then slowly resolve. Your foot and ankle is going to swell. The whole leg's going to swell. It's going to look pretty big. We put glue over the incision so we don't really let any of the fluid drain out. Your body will absorb it. It will go away. Going home, your family can take you home. They'll show you how to get in and out of a car in physical therapy, and they'll help you with that, and show you how to safe way to do that. If you do need transportation, the case manager will try to work on that to make arrangements. And if you're traveling a distance, you may want to stop every couple of hours to stretch. So a distance means, probably about an hour and a half, a 2-hour drive. I understand in the city of Chicago, an hour and a half, 2 hours could be only 10 miles. But in general, if you're going to be in the car for that much, stop every hour or so and get out and walk around just to stretch things out. At least the first time you're traveling. Your wound's going to be covered on discharge. We like to keep the wound covered in the hospital, but if your wound is clean and dry, you can leave it open to air at home. You can shower and leave it open. You can cover it if you don't want to see it. One thing to remember though is your wound will be covered with a glue, so make sure that you don't put any lotions or cream over there because that will break the glue down. For those of you that plan on going to rehab, your family can take you to rehab or the case manager will arrange for transportation. Your wound will be covered on discharge. In rehab, we still prefer your wound stay covered until you're home because rehab is still like being institutionalized and we prefer it be covered if possible. You can still shower though, and then you can dry it off real good and then cover it up while you're in rehab. Once you get home, it could be open to air. All orders from the hospital will be continued at rehab. Everything should be basically the same. If it's not or there are questions, again, call or email. We'll work on that. Sometimes not everything gets transferred quite as we like it to. So if it doesn't, let us know. We'll make sure that we get it taken care of. For physical therapy, this is a good part of your recovery. To be honest with you, a lot of the therapy though for hips is walking. So do lots and lots of walking. Do that abductor strengthening that I mentioned before with the leg going out to the side. The physical therapist could have shown you that in prehab. They'll show you that post-operatively. But if you do your exercise and a lot of walking, the physical therapy is not that bad and you won't need it for that long. Your swelling will subside by 3 to 4 weeks and your leg won't feel so heavy. Then you'll be really getting going. However, we do suggest you make sure you take it easy for about 6 weeks. As you start feeling good, swelling goes down. That doesn't mean to get out there running and jumping and high impact activities. The goal is to work hard, push through the therapy, keep your chin up, and recover at your own pace. There'll be no awards for anyone that plays the earliest round of golf. First person that walks 10 miles, there's no rewards or medals that you're going to get for that. So just for 6 weeks, take it easy. And that'll give you the best possible outcome. When we look at other surgeries, if you have an appendectomy, you have a gallbladder out, if you have even a hernia repair, typically they're not going to want you to do any strenuous activities for 6 to 12 weeks. We're just asking for about 6 weeks. Take it easy. It'll give you the best outcome you could possibly have. A little bit more about physical therapy. As your staples do come out, if you had staples or the glue slowly peels off, there won't be so much pulling around the skin to give you a little bit more stretching and less pain as you do range the hip. By 6 weeks, you'll be allowed unrestricted activity. So that means you're not going to have any precautions at all, and you're going to be able to do the things you want to do. It's okay to go back to exercising at that point. It's okay to go back to sporting activity. If you want to play a round of golf, that's completely fine. Leading up to that, chipping and putting on the golf course is certainly fine, but at 6 weeks we'll let you loose. But we still do not suggest high impact activities that will wear the hip out faster. That could even lead to loosening of the hip. So running and jumping are things we suggest you not do unless you absolutely have to. If someone's chasing you, run. If no one's chasing you, then if you want to walk, you can walk fast, but we wouldn't suggest running. Again, as I mentioned, PT is a little less important with the hip than the knee. So if you do a lot of it on your own, you'll be done with therapy relatively quickly and back to walking significant distances within no time. But again, heeding my warning of take it easy for the first 6 weeks. The routine follow-up we suggest is your first appointment should already be set up. You should set that up in the office when you book the surgery or at your preoperative visit so that everything is ready to roll. You don't have to worry about making that. If you have not, then call 432-2466, area code 312, for Stephanie or Kathleen to set up an appointment, usually 10 to 21 days after the surgery. First appointment is for a wound check, and that's really all we do. We kind of check your wound, make sure you're going to outpatient physical therapy, and that things are progressing appropriately. At 6 weeks, we get an x-ray, and that's when we go ahead and release your precautions. The first visit, again, is mostly for a wound check. For those who are traveling a great distance, Oftentimes we'll have you forego that first visit and have you come in, instead of 10 to 21 days, have you come in 4 to 5 weeks after the surgery. We count that as the 6-week visit. We get the x-ray, and we'll make the 2 visits turn into 1 for the people that do have to travel a great distance. And again, that's what I mean when I say special arrangements we made. We try to do that for people who are traveling a distance, and just make life a little bit easier that way. So I appreciate your attention in reviewing this video with me. Feel free to contact us again via email. Feel free to look at our website for more info and modules. This is obviously posted on our website, and any questions, don't hesitate to let us know. Hope that you found this helpful, and hopefully you're enjoying your new hip.